Hello, I'm Dr. Andrew Cutler, Clinical Associate Professor of Psychiatry at SUNY Upstate Medical University, and it's my pleasure today to be helping you with rater training on the ADHD RS5, CGI-S, and CGI-I scales. I've been doing clinical trials in ADHD for over 20 years, and I've done literally dozens of clinical trials. And over that time, I've done hundreds, if not thousands, of ADHD rating scales and CGI rating scales. And I've been involved with the development of pretty much every ADHD medication that's currently on the market. Let's start with the ADHD RS5, which stands for ADHD Rating Scale version 5, which is keyed to DSM-5. Now, this rating scale is a clinician-rated scale based on a clinical interview with the parent or caregiver of a child. With older children or adolescents, sometimes you will also bring them into the interview and get their perspective, but the primary informant is the parent or caregiver. Now, you'll notice there are 18 items on this rating scale, and these are essentially the 18 symptoms of ADHD that are used to make the diagnosis in the DSM-5. You'll also see that there are 9 inattentive symptoms and 9 hyperactive impulsive symptoms. In this particular version of the ADHD RS5, the symptoms alternate. So if you look at item number 1, which is failing to give close attention to details or making careless mistakes in schoolwork, that's an inattentive item. Item number 2, fidgeting with hands or feet or squirming in seat, is a hyperactive symptom. And so they alternate that way throughout the 18 items. Now you'll notice that each item is rated on a scale from 0 to 3, with 0 being never or rarely, 1 is sometimes, 2 is often, and 3 is very often. Now looking at the keys here, it sounds like this is a frequency scale, just rating how frequently the symptom occurs. But in actuality, the proper way to rate this scale incorporates also the severity or the impact on function. So for instance, if a symptom happens only a few times a week but causes very significant impairment or impact or distress, you might rate that up higher. So you might rate that instead of often or very often if it's causing a big problem. So you want to take into account both frequency and severity when rating each one of these items. At the end, when you've rated all 18 items, you add up the scores and you get a total score. Let's now look at each individual item. So item number 1, as I mentioned, is failing to give close attention to details or making careless mistakes in schoolwork. Now, this says schoolwork, but really it's important to understand not only the letter of the item, but the spirit of the item. What symptom is this trying to capture? And so you're going to have times, for instance, when the parent will say, well, they were out of school this week, so we don't have schoolwork. Well, what this takes into account is not paying attention to whatever they're doing. Being careless or sloppy or rushing through things, that's another way to use that item and to probe to get the symptoms that you're looking for. Always the child is going to have something that they need to be doing around the house, whether it's chores or other activities. Putting things away, working in the kitchen, whatnot, like that. And so again, that's looking for carelessness, sloppiness, or rushing through things. The second item, fidgeting with hands or feet or squirming in the seat, that is while they are seated, moving around, fidgeting, playing with things, having trouble sitting appropriately, for instance, crossing and uncrossing the legs, sitting on one of the legs. This also would incorporate doodling, which you sometimes will hear a parent talking about. The next one is difficulty sustaining attention in tasks or play activities. Now this is sustaining attention or staying focused is a term that I often use that sometimes will prompt people to say, oh yeah, when you say it that way. So you want to realize that you read the item, but then you also can translate or probe, because sometimes I have a parent say, oh, well, when you say it that way, then yes, they do have that symptom. So trouble maintaining focus. Now, this one can take into account distraction, but it's very important to realize this is internal distractions, not external distractions. That comes up later in item 15 of the scale. We'll get to that later. So this takes into account getting off track, getting distracted by their own thoughts, internal distractions. Number 4 is leaving seat in classroom or other situations in which seating is expected. Now, this is not how much they move around when they are seated. This is actually getting up out of the chair or having trouble staying seated. This can not only include classroom, but also mealtime or other situations, the family getting together and maybe playing a game, situations like that, or church or synagogue or something like that. The next one, number 5, is does not seem to listen when spoken to directly. So this one is, how hard is it to get them to pay attention to you when you're talking to them? How hard do you have to work to get their attention? Do you have to call their name or raise your voice? Item number 6, running about or climbing excessively in situations in which it is inappropriate. Now, this is fairly obvious what this refers to. This can be running around, climbing up on furniture, climbing trees, things like that. But it's getting to an element of hyperactivity, of excessive motor activity. Now, with older kids or adolescents, sometimes they may not be running around and climbing on things. The hyperactivity goes internal, and this might be expressed as a sense of restlessness or difficulty just doing nothing. Item 7, does not follow through on instructions, fails to finish work. Now, this is different from procrastinating or not starting things, which will come up in another item later. This one is they start, but they get off track. And so one way of probing this is, do they get off track when doing homework? Will they start the homework but not finish the assignment, or get off track doing something else? How about chores? One probe might be, do you find that you have to give them one task at a time? You can't say, do this, and after that I want you to do this, and then do that, because you find that they will get off track or forget what they were supposed to do. So do you find that you have to tell them one thing and tell them to come back to you when they're done with that so you can give them the next instruction or command? Item number 8 is difficulty playing or engaging in leisure activities quietly. Now, this is fairly obvious. Are they being loud? Do they raise their voice? Now, this is not talking a lot. This is more, are they loud? Talking a lot is going to come up in another item, but this is, do they play loudly? Are they one of the louder kids? Are they louder than other kids? Do they turn up the volume when they're watching TV or listening to music? If they're wearing headphones, can you hear the music through the headphones? That kind of thing. Item number 9, difficulty organizing tasks and activities. Now notice this says tasks and activities, so it has to do with time management and organizing yourself for an activity such as doing a book report or something like that. But it also has to do with organizing your space and the things around you, such as organizing your room or keeping your room clean, neat, and organized, organizing your backpack, your desk, your locker, your notebooks and assignments, how careful and neatly do they keep things. Now, sometimes you might hear that the patient doesn't have trouble with this. And when you hear a no, you always want to probe further, because while they may not have all the symptoms on this rating scale, they're going to have a good amount of them, and you want to make sure you've adequately probed for each item. So if you say, tell me more about that, how come they don't have trouble organizing? And the parent says, oh, well, I help them organize their room, and we have bins for everything, and every day I go over it with them, or I help them every night before school, I help them lay out their clothes or lay out their books. Well, now you're talking about the parent is helping to compensate. And this is an important point throughout the rating scale. If compensation has to occur in order to avoid the symptom from happening, then you would rate that, and you would rate it up a notch or rate it a little further. So usually you rate it up at least a notch. It depends on how much effort or how much time it takes to compensate, how much impact does the compensation itself have on the parent or caregiver's life or the child's life. Next item is item 10, on the go or act like they're driven by a motor. This is fairly obvious. This is hyperactivity. This is, do they wear you out? Do they wear other kids out? Do they seem like they're always on the go? Is it hard for them to unwind at the end of the day, for instance? Those are all probes that can help you with that one. Item number 11, avoiding tasks such as schoolwork or homework that require sustained mental effort. Now here again, what happens is this is keyed to schoolwork and homework, and you might have a parent say, well, we didn't have school this week. Well, you're going to probe then for other tasks such as chores around the house. Kids always have chores or things that they're supposed to do around the house, and do they procrastinate or avoid or delay getting started? And how often does that happen, and how much of a problem is that? How hard do you have to work to supervise the child or to coerce them or cajole them to get them to do it? Item number 12, talking excessively. Now, this is not necessarily talking loudly, although it can be part of it, but it's just talking too much, going on and on, being a chatterbox. Sometimes kids will get in trouble in school for talking when they're not supposed to, for instance, or during quiet time, things like that. Do they go on and on, especially about a favorite topic or a favorite subject, is one probe I've used. Item number 13, losing things necessary for tasks or activities. And what I often say is, do they lose or misplace things? Sometimes I find for some reason that they'll say no to losing, but when I say misplacing, they'll say yes. So as if, yes, they've temporarily lost it, but they eventually find it. Well, that's still losing or misplacing. Now, this is an item that I often get a no on, and I'll always probe a no and say, tell me more, how come they're not losing? Well, here again, okay, we have bins and we organize, and I help them all the time. I have to help them put their things away and organize the things so that they don't lose them. So this is not exactly the same as trouble being organized, which was an item previously, item number 9. This is losing or misplacing things. This can be schoolwork, supplies for school, toys, games, books, articles of clothing, not putting their shoes away or hunting for their shoes. Do you find when you're trying to leave that you're always hunting for something that the child misplaced or lost? Excuse me. Item number 14 is blurting out answers before questions have been completed. Now, this might be blurting things out in school, not raising their hand. This can also be when you're engaged in a conversation with the child, do they cut you off or interrupt you? Now, a very important distinction with this item, item 14, is between this item and item 18, which is interrupting or intruding on others. Now, sometimes they will say, yes, they interrupt me for item 18, but the essential concept here for item 14 is you and I are engaged in a conversation and I interrupt you. That's item 14. That's blurting something out or cutting you off is what I'll often use as a probe. Item 18, interrupting or intruding on others, is you are involved in a conversation with someone else and I butt in or interrupt you then. And the classic example of that is the mom's on the phone and the child is mom, is interrupting them while they're on the phone or talking to someone else. Or do they barge in or butt in on other kids when they're playing games or doing other activities? Item 15, easily distracted. This one is external distractions, not internal, distracted by your own thoughts. This is getting distracted by sights or sounds or clutter or things moving around you, that kind of thing. Do they often find that they look out the window because they're looking at things, daydreaming? Daydreaming can also be trouble with sustaining attention, item 3. So you have to determine if it's an internal distractibility or is it that they see something which prompts them to go off and daydream? Or do they hear things going on outside? Do they hear things outside the door at school? That kind of thing. Next one is item 16, difficulty awaiting their turn. And this is also impatience in general. And this can be impatient waiting your turn in a game, a board game, for instance, or waiting on a line if you have to line up, for instance, at school for the water fountain or the playground or to go outside or anything like that. Difficulty waiting their turn in a sports game. Is it waiting for their turn to be a batter or to get up and kickball or something like that? Is it tough for them to wait when there's a delay in general or something that they want is being delayed? So that one is fairly self-explanatory. Usually you can get the parent to understand that one. So it's not just difficulty waiting your turn, it's impatient in general. Item 17, forgetful in daily activities. And one of the probes I use is absent-minded or forgetful. Do they forget what they were supposed to do? Do they forget to bring something with them? This is a big one. Do they forget to bring things home from school? or bring something from home to school. That can be a big one. That can be a backpack, a book, a schoolwork assignment, their lunch money, a permission slip, things like that. So forgetful, absent-minded. Do they forget what they were supposed to do? Is there something that they have a chore that they're always supposed to do, or grooming, brushing their teeth, brushing their hair? They know they're supposed to do it, but they just forget. They're absent-minded. Item 18, we already reviewed. That's interrupting or intruding on others. And again, the concept here is that this is not when you and I are talking, I interrupt you or I butt in. This is two people are engaged in something else, or other people are engaged and the person interrupts them or butts into a situation that they weren't part of initially. And so those are the 18 items of the ADHD RS5. Now, it's important to realize that this is really trying to capture the frequency and severity of the 18 core symptoms of ADHD from the DSM-5. And it's also important to realize that the time frame you're looking at here is the past week or the past 7 days. So it may be longer than a week since you've seen the patient, but you really are capturing the past 7 days. In the past week or the past 7 days, how often has this happened or how much of an impact is it? And it's very important to really probe and carefully establish a baseline here, because this is a very important measure of what's going on with the symptoms and their impact. And you want to have an accurate baseline so you can compare it to subsequent visits. And when you're doing your subsequent visits, it's always helpful to go back and compare to the baseline and even the previous visits ratings, so you can get a sense of what's going on. What we're searching for here is to detect a real change, ideally improvement, but also to make sure that things maybe sound a little better but haven't really materially changed or significantly changed that much. So the goal here is to compare and to get that accurate baseline so you can establish or detect an accurate change, if there really is one. Next, we're going to review the 2 CGI scales, and CGI stands for Clinical Global Impression. The CGI-S is Clinical Global Impression Severity, and the CGI-I is Clinical Global Impression Improvement or Change, and we'll get to that in a minute. Let's first start with the CGI-S. Now, the concept here is this is an experienced clinician's assessment of the overall severity of the patient's condition, in this case ADHD. So we're really focusing on the ADHD symptoms and impact on function here, not necessarily other things. And the way this is written is it's one question with seven options for rating this item. And the question is, considering your total clinical experience with this particular population, again ADHD, how mentally ill is the patient at this time? So you're really focusing here on the past week. It's the past 7 days that comprise the time frame for rating this scale. And you'll see here there are 7 choices. The 0, which is not assessed, of course, should not be an option because you're going to assess this. So your items are 1 through 7. 1 is normal, not at all ill. Essentially, maybe they have a few symptoms, but they're really not any more than a kid without ADHD might have, because we all occasionally have some symptoms. 2 is borderline mentally ill, which is, yeah, there are a few symptoms. They happen sometimes, but they're not causing any significant problems. 3, mildly ill means there are clearly established symptoms. They're definitely there, but they're not impairing function or causing much in the way of distress. And the essential distinction between a 3 and a 4 is when you get to a 4 is you've got established symptoms, but they're causing either distress or impact on function or some degree of impairment. That's when you go from a 3 to a 4. Now, the difference between a 4, which is moderately ill, and a 5, which is markedly ill, is the frequency of the symptoms and the amount of impact on the function and the distress level. A 6 would be severely ill, and this would mean very frequent symptoms, many symptoms happening quite frequently, and having very significant impact, almost incapacitating or causing major disruptions of their life. A 7 would be the most extremely ill, amongst the most extremely ill patients you've ever seen, the worst cases of ADHD you've ever seen. Typically, those are not enrolled in clinical trials, but it's certainly possible that they are. So that's the essential concept of the CGIS. The CGIS, what I like about it is the CGIS approximates how we practice in our clinical practices, not just in a research setting, because this is really asking, and we always make these judgments, how sick is the patient at this time? Are they mildly ill, moderately ill, severely ill? Are the symptoms very significant? Are they causing impact or distress? And so as clinicians, we're making these global assessments all the time. And this is just a way of codifying or quantifying our clinical judgment that we would normally use when seeing a patient at a particular visit. Now, the CGI-I, or Clinical Global Impression Improvement, is really a little bit misnamed because we don't want to necessarily assume that there's only going to be improvement. They may not change or they may worsen. So some people have also called this the CGI-C, or Clinical Global Impression Change. But the standard convention most of the time is to call it CGI-I, which is Clinical Global Impression Improvement. Like the CGI-S, this is asking one question with 7 possible options to rate. So there is one number that you assign for this question or this rating scale. And the question that's being asked, again, is an experienced clinician using your judgment, rate the total improvement, whether or not in your judgment it is due entirely to treatment, compared to the patient's condition at admission to the project or at baseline. How much have they changed? And so this is very important in order to rate this, that you go back and actually look at your rating scales from the baseline visit or the pre-treatment visit. And I would look at the ADHD-RS as well as the CGI-S to get a sense of what was going on and how significant the ADHD severity was. And then it's a matter of comparing that. And the time frame we're using here now is in comparison to baseline, taking into account the symptoms and behaviors of the past week. Again, the past 7 days is what forms the basis for this rating. Now the options here, again, 1 through 7, a 0 is not assessed, you're not going to do that. A 1 means very much improved. This is a very substantial improvement. They're virtually all better, virtually in the normal range with very few symptoms, if any, causing no impairment or distress whatsoever. A 2, much improved, means a significant improvement. They may not be completely symptom-free, but there's been a very noticeable, significant improvement, not only in the frequency of symptoms, but in their impact, the level of impairment or distress that they're causing. A 3, which is minimally improved, is, yeah, I think there's some improvement. Maybe the symptoms are a little better, but it's not a substantial improvement. It's not causing a significant functional improvement or a significant decrease in their level of impairment. So this is kind of, I always say, if you're squinting a little and go, yeah, I think they're a little better, that might be a minimally improved. No change, of course, is self-explanatory. Essentially, there's been no clinical change either in the frequency or severity of the symptoms or their impact. A 5, minimally worse, would again be, yeah, they're a little bit worse. The symptoms are a little worse, but it's not necessarily making the impact that much worse. A 6, much worse. Clearly, there's been an increase in the symptoms or their degree of impairment or distress. And a 7, very much worse, of course, would be a very significant worsening of the condition. And again, it's important to not make judgments here, to not try to determine, is this from the treatment or not, what's causing this, but basically call it as you see it. And that's, again, why it's so important to establish that accurate baseline, because we want to compare this to that baseline and try to detect a real change if there is one. This is Dr. Andrew Cutler. I want to thank you for your attention and for your diligence in trying to learn these rating scales and understand not only the letter of what's written on the scale, but the spirit of what they're trying to accomplish and the spirit of the symptoms and the impact that we're trying to assess. It's very important, again, to try to establish accurate baselines, because the goal here is to try to detect a real change, a meaningful improvement or no change or worsening, but to detect a change that may be going on. And the data that you collect, think of this as the data or the measurement, the tools you're using to measure things, is very vitally important in order to be able to assess what's going on. And the more careful you are, the more detailed you are, the more diligent you are, the more data you're going to get and the better determination you're going to be able to make overall. So I want to wish you good luck in your clinical practice and using these tools to help you in what you do.